Yeah, please. Well, thank you for allowing me to be here. I used to live in Nashville, so I feel back at home in Tennessee. We moved over to South Carolina last fall over near Hilton Head. So somebody's got to do that. So here, that'd be me. But when I flew into Knoxville this morning, I was like, oh, back to Tennessee and your beautiful weather. So I'm happy to be here. But I am the Director of Oncology Key Accounts for the Mid-South for Astellas. And my role is a little bit different. I don't do anything with sales. So if you ask me a clinical question about one of our products, I could probably know enough to be dangerous. But I've been in the oncology space now for about 15 years. And my role is to bring what we call above the brand education. So things like anything having to do with healthcare delivery, oncology, MACRA, the alternative payment solutions, patient navigation is a big topic these days, financial toxicity and things like that. So today, in talking with Terry, I'm going to talk a little bit about improving oral oncolytic adherence. So can I just see from a show of hands, is everyone here clinical, and do you guys all work with patients? Is everyone? Okay, so everyone does. Okay, so as I go through, I would love to have your input and your feedback so that you're not listening to me for the whole time. But we're going to just kind of talk about a topic that I'm sure you all deal with every single day. But the whole point of this is obviously to give you some education. I don't know that it's going to necessarily be new education, but at the end to actually give you some ideas for applicable resources that you might want to use or maybe look up and see if it might be helpful in your area. So with that, the agenda for today, we're going to talk about the importance of adherence, specifically oncolytic adherence. What is the current and the most recent existing data for non-adherence and persistence? What are some barriers that we see or that are known for adherence, and then some publicly available tools and support systems that may be helpful to you. Sound good? Okay, so former U.S. Surgeon General Dr. Koop, obviously drugs don't work in patients that don't take them. Why don't patients take them? There could be a myriad of reasons, but the key thing with a favorable outcome, obviously, is patients need to take the medication as prescribed and also the actual medication for their disease. And as I've gone and talked with different organizations around the Mid-South area, I'm amazed by the stories I hear about how patients take other people's medicine, or they'll take medication that was expired 4 years ago, or what happened. And a lot of it is due to obviously financial. Do you guys hear that a lot and see that? So first we'll talk a little bit about what is adherence. So a lot of people, when you say adherence, the first thing that comes to mind is taking the medication. But adherence actually has a lot of different definitions. Obviously, refilling or filling a prescription on time is part of adherence, taking the right amount of medicine, taking doses at the right time. So if it's a morning and night, did you take it morning and night, or did you forget one night, or what have you? Taking medication for the full length of the prescription. So I was preparing for this talk today. I was like, oh, I'm kind of one of those people because I just had to take some antibiotics for a sinusitis. And I'm like, oh, I didn't finish all my Augmentin, so I'm one of those. Only taking medication that was prescribed for the problem diagnosed by the doctor also is part of adherence. Only taking one's own medication, going back to what I had just mentioned, and then remembering whether medication was taken. So those of you that are talking with patients, when you ask, did you take your medication, if they can't remember so that you can get a definitive answer, then that also contributes or is a definition of adherence. Actually, non-adherence in that case. So what is non-adherence is obviously the opposite of everything we just talked about. But some things that I'll point out here is also taking a lower dose or higher dose than prescribed. So sometimes folks, especially with oral oncolytics, will cut their medication in half because they're trying to make it go longer. So the key thing there is as prescribed, stopping medication early, taking an old medication for a new problem, See that sometimes. Taking somebody else's medication and then obviously forgetting when and if they took the right medication. That one comes in more, wouldn't you guys agree, if somebody's on multiple meds for different disease states and they kind of forget, did I take in different regimens? That seems to be the case. One thing that we talk about here is the difference between persistence versus adherence. Because a lot of times, or compliance, those three words seem to be used intermixed a lot. And there's actually a pretty big difference. So persistence is the days adhered to the drug regimen divided by the total prescribed days. So if somebody was prescribed a drug for 90 days and they adhered to it for 45, then we would say they had a 50% persistence, or PDC, proportion of days covered. You might hear those terms. So I just want to make sure everybody's clear, because sometimes that can get confusing. So any questions about that? It's pretty straightforward. So what is the potential impact of poor adherence? Obviously, poor outcomes. So, you know, as you're thinking about and you're treating patients, and patients are expecting certain results, if they're not taking the medication as you imagine they will, or as they are prescribed, then chances are the outcomes are going to be very poor. And this one is a kind of a big deal, the increased medical costs. So you think, well, yeah, it's going to be a burden on the healthcare system. But interesting, the data shows from a New England Healthcare Institute study that non-adherence, along with suboptimal prescribing, administration, and diagnosis, could result in $290 billion per year in avoidable medical spending, or 13% of total healthcare expenditures in the U.S. So when we think about what's happening today with healthcare costs and everyone, the Affordable Care Act, and all the things that are going on in our healthcare system, just imagine. So when we're talking about adherence, it really is a pretty big topic, a pretty big deal. So when you think about that adverse health outcomes and not getting the outcome that you expect or that you would want, there was some data looking back at the 2000 health and retirement study, and they looked at data of older Americans that are community dwelling adults, and they looked at folks that had chronic disease that required medication. So things like diabetes, hypertension, those types of disease states. And what they found was that Medicare-aged folks, or those older Americans, especially the ones that had difficulty paying for their medication, if there was a financial element at play, tended to state that their health care was worse. They felt, when they were subjectively asked, that they felt that their health care was worse than others that didn't have the financial burden. They also had more hospitalizations, more general symptoms, whether that was from the disease or maybe even side effects from medication. They also had more depressive symptoms. So when I mentioned financial toxicity and the financial piece, that really truly does play into not just the adherence piece, but the overall total healthcare costs that are coming into play in conjunction with outcomes as well. And then this is an interesting study when you get into when you get into cancer patients specifically. There was a study in 2011 by Amir Ibrahim, I'm probably murdering that name, but he looked at patients prescribed imatinib. And what they found was that non-adherence might be, or in that study showed that it probably was, the most important factor related to cytogenic relapse. So because patients weren't adhering to that particular regimen, it wasn't that the drug itself wasn't working, it was that patients weren't taking the drug, and that's the reason, or weren't taking it correctly. There was a second study done by Dr. David Martin, same exact thing in terms of the outcome, that it showed that non-adherence in this particular CML disease state. So when you think about how important that is for your cancer patients. It really is kind of an alarming statistic when you think about that. This is a quote by Dr. Obel from ASCO's Cancer Communications Committee, and I put this in here because when you think about when you look at the pipeline of drug companies, and you look at what's coming in the next 3, 5, 10 years, huge majority of oncolytics are oral. It's where everything's headed, oral. You know, we all know that that's what you've probably seen come out recently and will continue. So when you think about oral compliance and adherence versus infused or injected, it's really a very difficult thing for you, I'm sure, as healthcare providers and as clinicians to monitor. Because if someone's coming in and getting infused and sitting in the chair, you know they're being compliant and they're being adherent. But when they are taking oral medications that you can't monitor, that's really starting to be a bigger and bigger problem. Are you guys seeing that as well in what you're doing every day with patients, and they're not being 100% compliant, or they may not know that they're not? So here's some data that we have. I'm going to start out just talking a little bit about general adherence data. I know we're talking about oral oncolytics, but I wanted to start with some disease states that are pretty well known. In the cardiovascular space, when you look at adherence data in cardiovascular disease, 43% of patients with cardiovascular disease, could be hypertension, could be congestive heart failure, could be, cardiovascular disease is obviously broad, but when you think of 43% are non-adherent. And what does that lead to, or what could it lead to? When you look at persistence with statin therapy, so on the left, remember PDC is proportion of days covered, you see that statin use declines sharply after the initial therapy begins, and then over time it continues to decrease, and by 60 months, that proportion of days covered drops to 35% on a statin. So that's the data that we're looking at. So now let's talk a little bit about what's happening with cancer medication. So in one study that was done, 10% of patients abandoned their oral medication, oncolytic, and another 25% had some delay in initiating therapy. A lot of times the delay is the actual accessing the medication. It could be due to financial issues or payment, or getting the medication through specialty pharmacy or what have you. In another study, 45% of cancer patients with significant or catastrophic financial distress were non-adherent due to cost-related issues. So this second study was specific to cost-related issues. So of that 45% that were non-adherent, 4% took medications prescribed for another person. 22% took less than the prescribed medication. We typically see this if something is dosed 2 or 3 times a day, they'll maybe take 1 a day. Again, the theory is, in their mind, is to stretch out the medication as long as they can. 27% didn't even fill their prescription, never even filled it, so a quarter of patients. And 25% filled only part of the prescription. So again, when you're thinking about almost half of that population, that was the breakdown of numbers. So I'd love to get your thoughts on that. Does that go along with what you guys see, or any feedback? It's pretty alarming, I think. So when you look at barriers to adherence, there's really 5 types of barriers to adherence. The first is socioeconomic status. So this kind of goes back to the health literacy. The ability of someone, it could be a language barrier, but it's the ability of someone to understand and comprehend what is being told to them and how to complete their medication regimen. It could also be transportation issues. It could be anything having to do with them actually in their socioeconomic bubble or their world, being able to take the medication, get the medication, and finish the medication. The second is the healthcare system, and this speaks to the relationship of the patient with the provider. And is the provider able to communicate with the patient in such a way that they understand what they're being told? Is the provider aware of adherence issues that may come into play and being able to address them early and being able to help the patient through that? So that's what we mean by healthcare system. And then the disease itself, and this goes back to those diseases that are typically asymptomatic or that present later from the disease progression itself, or side effects or symptoms, that are typically not severe. Whoops. And then the treatment regimen. So this is talking about, does a patient understand the treatment regimen, how to take the medication, when to take the medication, how to report side effects, and being able to understand those types of issues. That's a huge barrier to adherence, as you can imagine. And then last is the patient itself. So this, him or herself. This goes to thinking about the patient's psychosocial behaviors. Is there a substance abuse issue, alcohol abuse perhaps? Is there anything, or is there a lack of caregiver support? Anything having to do with the patient's ability to being able to actually take the medication as prescribed. So when you think about that, this is a good case study. So imagine that this is the gentleman you're seeing on the screen is maybe a 61-year-old Hispanic male, just been diagnosed with prostate cancer, maybe living in subsidized urban housing, single, moved to the States when he was maybe 35 years old, speaks little English, and also is currently taking anxiety and depression medication. So as you can imagine, there's a lot of things already happening, and he's probably, a lot of times, patients that are maybe experiencing side effects or some issues from other disease state medications are even more apprehensive to take more medication because they're afraid it's going to make them feel worse. And so that's just an example of, you know, how the barriers to adherence can really be quadrupled and tripled and so forth when you're talking about patients that have multiple barriers that would affect how they are able to manage their medication, understand their medication, and ultimately take their medication, especially, as I mentioned before, if you're dealing with multiple disease states, which most cancer patients probably are. How are they managing those, and do they understand what each one does and how to report side effects and so forth? So I mentioned before health literacy, and just kind of going back to that because we're continuing to see this as being a bigger and bigger issue. So I was kind of surprised when we were talking about this before that only 12% of adults in the U.S. have proficient health literacy. And again, health literacy is the capacity to obtain, process, and understand basic health information. And so when you think about 12%, now we're thinking about, you know, the number one, in working in the area that I work in prostate cancer, the number one feedback that in a previous company that when we were doing some patient education came back to us as it was written at too high of a level. Patients couldn't understand what we were trying to tell them because it was at a much higher level of understanding. And that was a big eye-opener, I think. You know, so it goes back to, not that people are, you know, not intelligent. It's just, if you're not in the medical field, there's a lot of words that we use and that are part of the process that patients just don't understand. When you look at older adults, and I'm not sure what they quantify as older, so I'm going to say Medicare age, so because I want to feel really young, so I'm going to say Medicare. But 71% of older adults, older than 60 in this particular instance, have difficulty using printed materials. Now it's interesting because if you also think about Medicare-aged folks, where's everything headed right now? Everything's kind of digital. We're all going digital, apps and stuff. So we're a little bit in a catch-22 because a lot of those folks don't feel comfortable doing the digital way of communication, but they also, 71% had difficulty in printed material. 80% have difficulty using documents and forms and charts. It's very overwhelming. 68% have difficulty interpreting numbers and performing calculations. So again, when you're thinking about oral oncolytics and the typical, although I hate to even say that typical anymore, but the typical age range of folks that you're serving, a lot of times you are looking at folks that may kind of fall into some of these categories. So what are some tools that can be used to overcome adherence? Obviously, anything that is interactive seems to be what patients prefer. Live educational sessions, I know there's a lot of videos online. The written materials, again, I think the caveat there is just making sure that it's at a level that folks can understand. Appropriate languages, and then also the reading level. So when you guys here at UT, do you have, I know you probably have English and Spanish materials. Do you have any other languages that you guys see as predominant? Yeah, I don't find, except in the metropolitan DC areas so far. So obviously when you think about who's talking with the patient and who's counseling them, when you hear HCP or healthcare provider, there's a lot of you in the room that fall into physicians, nurses, case managers, pharmacists, the list can go on, social worker, navigators, financial reimbursement folks. So there's a lot of people that one patient is typically interacting with. And so everyone kind of needs to have the same understanding of where that patient's coming from and what his or her challenges may be. Also, we just talk a little bit about motivational interviewing. I'm not going to go into a huge depth about motivational interviewing. I'm sure you guys have probably been through something similar, but I will just do a very quick reminder of when a patient is being counseled and when you're talking with them, they typically go through and you're wanting them to have a behavior change. There's really 5 steps. So the pre-contemplation phase is where the patient doesn't even think there's a problem. There's no reason to change because there's not an issue. And that's when you're asking great questions and you're really trying to get them to kind of understand what the issue might be. Contemplation is when they're thinking about making a change and they're kind of open to that, but they're still ambivalent about it because they don't see that their behavior is contributing to the issue. The preparation stage is where they've decided, I'm going to make a change. I need to do things differently. And so that's when they're really kind of making the game plan. The action phase is doing what they say they're going to do. And then the maintenance is making sure that there's no relapse back into bad or unwanted behaviors. So are you guys familiar with motivational interviewing? I'm sure most folks that were in the healthcare profession have been through something similar. And then just some skills, just as a reminder, the reflective listening is really key with patients and hearing kind of what they're not saying, reading between the lines. And a lot of that comes from asking good open-ended questions where they can't answer yes or no. Tell me more, help me understand how this happens. You're asking questions that are open-ended. And then summarizing at the very end. So here's what we talked about, here's what we decided we're going to do, and this is, are we in agreement? And that seems to be very helpful when patients have gone through a counseling session or when they've sat down with their pharmacist or when they've sat down with their nurse. If you summarize, it'll be a good trigger as the last thing they hear before they leave to summarize what the plan was. Here are just some additional, if you're interested, a lot of good information on these 2 sites around motivational interviewing. If you are so inclined, I'm happy to get you those sites. Another solution or a possible solution for adherence with oncolytics, oral oncolytics, would be treatment regimen. So obviously, when you're looking at how often does a patient take not just their oral cancer medication, but what other medications are they taking and how does it fit in? And data certainly has suggested that there's anywhere from a 10 to an 11% increase in adherence when patients went from a twice a day to a once a day medication. So there is good data out there to suggest the more simple a treatment regimen is and can be for a patient, the more adherent they will probably be. Obviously, support groups are very important for cancer patients, especially newly diagnosed cancer patients, and the timing and the frequency. So I'm sure you all deal with newly diagnosed patients every day that really need a lot of emotional support, and especially those folks that may not have the support with caregivers or family or friends or what have you. So the key really is the early intervention and getting patients started with that resources early on gives you the best outcome, and then follow up to make sure the patient's staying on track with those as well. And then we're going to talk a little bit about some technological solutions. It's kind of the last piece of this, but as I mentioned, there's, talking about adherence is one thing, but what can we do to actually improve it? And there's actually quite a few solutions and companies out there that are doing some pretty cool things, and I'd love to know if you guys are using anything like these. So there's a company out here called AdhereTech that makes wireless pill bottles. So when a patient takes their medication, it actually records that in real time, and it will send the information back so that if they miss a medication, if they miss a dose, or they're not adherent, then the healthcare provider, whether it's the nurse or the caseworker or whomever, gets notified. And so it's a great way for patients to be able to report without really reporting. So it's AdhereTech, and they also can send customizable alerts and text messages to the patient. Did you forget your medication today? Or don't forget your PM dose, or something to that effect. So again, the adheretech.com is where you can check that out. So that's one solution. This company called Medisafe does cloud-based platforms for mobile devices. And what this is kind of an interesting concept, because this also facilitates adherence to schedules. So it will also communicate with the patient. And they've had about 2 million users, have had about 160 million useful medication doses, and it's for Apple and Android both. So again, if you're talking about patients that are tech savvy and are willing to do something like this, it really does have a lot of collaboration between patients and caregivers and the providers. So it's a good way of a feedback loop for self-reported outcomes, as well as the adherence to their medication regimen. So Medisafe.com. And then, I don't know if you say Proteus or I say Proteus, but this is a digital medicine, and this is basically wearable sensors. So if you think about like a Fitbit or something to that effect, that's where this company is actually operating. And so this helps to communicate with a patient when they take the drug, and then it also helps, it's almost like decision making. So again, it also can report data back to the healthcare provider as well. So you've got anything from wireless bottles to wearable sensors to cloud-based applications. And then the last one, NextIT. This seems to be the most popular of again, the folks I've talked to anyway, because they're probably a little bit more advanced in what they're offering. But they basically do a virtual health assistant. So imagine on your phone, they can conduct at-home patient screenings and provides the result, again, back to healthcare providers. It helps remind patients to take their medication. It also has a diet and exercise function, so it helps patients remember to try to eat healthy, to do their exercise, and generally lead a healthier life. And then it also answers very, I would say, high-level questions about their disease management, and then it prompts them to schedule appointments. when necessary. So it's a little bit more of a holistic view and a holistic application. So again, that one's called nextithealthcare.com if you're interested in checking that out. And then obviously pharmaceutical companies and biotech companies have hubs and patient assistance that is available as well to patients that qualify for that. Also some educational things, 24/7 nursing hotlines. These are examples of what some pharmaceutical companies will offer. Electronic newsletters, that seems to, again, I mentioned earlier that everything seems to be kind of going to a digital age. And so our newsletters, at least what I'm seeing, is we're really trying to provide both, like a PDF that you can print on demand, as well as printed materials that patients can take with them. So really, when you think about adherence, to really sum it up, there's two different components. There's obviously the behavioral component with the patients, and then the informational as well. And so you want to be able, a multimodal approach seems to be the ideal way to approach adherence, especially with cancer patients. And that seems to give you the best strategy for outcomes. So I'm happy to answer any questions. You guys have been a quiet group, but you may have any questions or anything you found interesting. Are you using any of those by chance?
I haven't seen it.
No?
The pill bottles, is that something that a specific pharmaceutical company will be using for their medicine, or how do you get those for your patients?
So I don't know of any pharmaceutical company that's using them yet. I think that most pharmaceutical companies are researching a myriad of ideas for how to best handle that. I think the issue that you run into a lot with pharmaceutical companies is most of our medication is distributed through specialty pharmacy versus a retail pharmacy, and so there's just some distribution hurdles that we would need to get over. But there's definitely interest in that type of technology because it provides such a good feedback loop. Yeah.
So we do clinical trials.
Mm-hmm.
So our patients keep diaries, whether they're electronic or paper diaries, often of what they take.
Mm-hmm.
But where you're relying on a patient, and a lot of them probably just fill that in before they come in for their appointment.
Right, to the best of their ability.
So, right.
Yeah.
So I was just curious where that was.
Mm-hmm. A lot of I think you're going to see, again, with more and more oral oncolytics coming on the market, you're going to see, I think, more and more solutions. And there's going to be probably, things that we can't even think of right now. But I think the gap is still going to exist, though, for older Americans and older patients between being digitally savvy and being able to do what we...
That was surprising. That high number was surprising.
It is. But it's that's kind of the world we live in terms of what, and as baby boomers continue to age, the volume, you can imagine, will probably just continue to increase. So, any other questions? Well, thank you all for coming. I hope it was helpful and informative. But I appreciate you being here, and please make sure you sign in for all of our Happy Pharma folks.